Welcome to CSIS Online. The way we bring you events is changing, but we'll still present live analysis and award-winning digital media from our Dracopolis Ideas Lab, all on your time, live or on demand. This is CSIS Online.
Good morning. Welcome to CSIS. We have a great discussion today on artificial intelligence, healthcare, and research. With us are two real experts, Wendy Nilsen, the Program Director for Smart and Connected Health and Acting Deputy Director for the Information and Intelligence Systems at the National Science Foundation, and Caoimhe Vallely-Gilroy, who's the Global Digital Healthcare Business Lead at Merck in Darmstadt, Germany. So thank you both for joining us. The conversation today will be very much a focus on what are the benefits of the use of AI? What are the benefits of the use of data for healthcare? And we'll have a set of questions. You can send your questions in through the functions here on Zoom. And if we have time at the end, we'll get to them. So with that, let me start with a softball. Why don't both of you tell us about your jobs? Wendy, Caoimhe, what is your job? So you want to describe it?
You want to go first, Wendy?
Why don't you?
so I work for Merck KGaA in Darmstadt in Germany, or EMD Serono for the US colleagues. That is our legal name within the US. My responsibility and my job is to build the digital ecosystems around our molecular products. So we're very much, and COVID has shown us greatly the impact of technology and how that can really support clinical treatment, not just from the perspective of the development of new treatments, molecular treatments, and the speed of getting them through, but also the benefits of that support system around it, whether it be from actual applications that allow you to track your own health data and make decisions based on your own health data, but also the ability to feed back longitudinal data collection points to healthcare providers so that there is a much broader and wider picture of a human, regardless of whether you're healthy or have a condition. It's much more about really building that autonomous ownership, the data baseline, and this entire data picture around a human as we go through our lives. And so my job is to look into different solutions that are going to maximize the value and the efficacy of our drugs on the market, and support our patients as best as possible.
Great, thank you. Wendy.
So I think I was wise to go second because our goal, I'm at the National Science Foundation, and so we do the fundamental science for the country. And so I'm in computer science and information science and engineering, and we build the technologies that that allow for this commercial development. We are, we're developing AI now. We're building new systems for AI. What we're talking often about is the use of AI, but in health, we often need new tools. We need new tools for patients. We need new tools for providers. We need systems that work in a different way. You can build an AI system for a factory, and if something goes wrong, that there's a fault tolerance that makes sense. Often there's not a fault tolerance at all in health. So what we've done is, this is an initiative that I lead with the National Institutes of Health. And what we're doing is bringing together the cutting edge computing and engineering research with the biomedical community, because what we found was often computing was trying to build something for the health world, but they didn't know the real problems. They only knew what they saw in their hospital, not what was happening in the research world. So they were always recreating something that was on its way to production, right? But it wasn't quite there. So now what we have is these teams creating these tools, methods, devices that then we have partnerships built. And when we build those partnerships, they can get these things through much quicker. So that's our goal, is to bring really what is cutting edge work into the health domain, because we didn't see it there before and we thought there was a real gap. So we joined forces to make this happen.
I want to come back to cutting edge, but let me do a sort of foundational question for both of you. When we say artificial intelligence, when we say AI, what does that mean for you? I mean, I can tell you what it means for me, but I come out of a compute background. So what does it mean for you? Wendy, you want to go first?
So AI is a very broad term, and we even at the Science Foundation struggle to define it because it's constantly changing and growing. Most of what we're talking about in AI are analytic methods that allow for processing very diverse, heterogeneous data in a really rapid way, with increased accuracy often. So, but it's also some of what underpins our robotics world. It has to do with computer vision too, image analysis. So there's in natural language processing. So if you want to have somebody who's translating speech, that's AI driving behind it. So that's what I think of when I talk about AI.
Caoimhe?
Yeah. So for me, AI is I'll follow behind Wendy on that. There's a lot of what she said, and I wouldn't repeat it. But for me, AI, if I look at it very much towards the patient perspective and the treatment perspective, it is how do we leverage and use the vast wealth of data to make treatments faster and better for our patients? So how do we leverage the data? How do we build the models that are going to help find the molecules that are going to be of most need, that are going to understand better the mechanism pathways, the molecular pathways of diseases, and identify targets for drugs to be developed around. And it's from that perspective very early on in the drug development life cycle, right up to how do we support understanding behavioral change for patients that may be able to increase how well that their drugs are actually absorbed. Are we able to understand that depending on different demographic data points of a particular person, are they going to have better absorption rates in the morning or in the evening? How do we ensure that they use that? Right up to leveraging how do we use the data that is collected from healthcare providers in a commercial space. And I don't mean personal information data about patients. I very much mean sales data and behavior and commercial behavior data as well. It's all around how do we get the right drugs to the patients at the right time and as fast as possible.
So let's stick with data for a minute. What are some of the data challenges? When I used to do this stuff, which was a long time ago, so hopefully things have gotten better, the first part of any project was you had to clean up the data, right? And what are the challenges now? I mean, you've got access, formatting, governance. Maybe we can talk about each of them. But when you talk about data, how do you get it first? What are the sources of data for you?
I think the sources of data are as kind of diverse as the questions that we're asking. I mean, there are some data sources, many of the federal agencies have collected data. There are private sources of data. And there also are local community, research centers who are collecting data. So, I mean, and there's pharma data, there's all sorts of data available, but there's also devices. I mean, if you think about the Internet of Things, there's a lot of data coming in from there. So, in people's lives, if you want to understand behavior, you can't run a test. You need to collect the data. So there's all sorts of sources of data, including, coming in from outside sources. We've done some interesting projects around COVID where industry data has come in non-health fields to try to drive how do we understand how the disease was spreading. So I think that the sources of data are immense. But, as you said, cleaning data, that's a huge issue. And it's not just cleaning data, it's understanding data provenance. Where has it been? How's it been managed? How's it been handled? Metadata, explaining what that data, how it was measured, how do we understand it? It's a real challenge. And if you can, if you can compute a huge amount of data in a rapid amount of time, we can get around, if we can get enough data, we can get around some of these weaknesses, but there are huge challenges to the data. And then, in health, in other areas, like I said, in manufacturing, missing data might be missing at random. In health, we just know that missing data is not missing at random. You might not put down, after you eat a cupcake, you might not put that in your behavioral record, right? You might put, I had the salad, but not the cupcake for dessert, right? So there's all sorts of things that might not be missing at data and that might have really, I'm making a joke with the cupcake, but there are things that are in there that could have really severe consequences. So we have to figure all of this in when we're thinking about AI in healthcare.
No, we were all laughing because we know the cupcake example is I've at least done it, and that you get into double blind then, but maybe we can talk about that later. Caoimhe, I didn't mean to cut you off.
Yeah, no, I was actually just going to say that, it sounds like, Wendy, you know exactly what my behavior approaches are as well. I have that horrible habit too. But no, I agree completely. One of the challenges that we have within healthcare is not only are there huge numbers of areas that we can get data from, but it very much depends on what type of data we're looking at as well. And we have this huge range of data that we can pull from. And one of the challenges that we need to understand for us is what is the relevancy of the data. So we can collect data from all over the place, but which data points are going to be the ones that are really key and that aren't just background noise. So, and even within, if we go back to Wendy's point with regards to the cleaning of the data, without having those standardization requirements, we even struggle within different data pools, for example, to have that same consistency of data quality. So, if I look at getting genomic data versus getting wearables data from an individual, those are going to be completely different data types, and they're going to be completely different standards of the data quality that comes in. But even within, and that could be from different types of wearables that are being used, or it could be from different assays that are being developed. This is a real challenge, because being able to find the kind of the correlation between these points and matching is a big challenge.
So how much of this is publicly available? You mentioned wearables, and so we know that the companies that offer wearable products collect a lot of data on behavior. You maybe, if you're honest, you put in the cupcake. If not, you say you ran a mile or something. But how do you get access to it? You have to buy it? Is it what's in the public domain? What are the data access problems that you face?
So, that's a really, really interesting point. And I think the defining what is in the public domain is pretty much quite key to that. There's a big difference between data that is generated by users of a wearable from a private company, which is a public company that is owned and separate, and data that is released or published in large data sets that is available to the public. And I would say that there is an extremely limited number where that number of those data sets from wearables that is available. Those are definitely, you're looking at essentially that, yes, okay, wearables at the moment are primarily, they're being used as health consumer products. They're not necessarily being used specifically as medical products. But if you want to be moving that into that arena, then we really need to be looking at the fact that that is actually medical information from people that needs to be treated with the same amount of it's the same amount of security, it's the same amount of access rights as other medical information, and that's where it starts to become quite challenging with regards to the access of it and what is public, what is and what should be actually publicly available, and that's a big highlight there, and that links down to very much the owners of the data as the person originally and what they consent for that data to be used either publicly or privately by companies that own or buy it.
So I will say too, I want to build on that because, one of the values of AI is finding patterns, but when you combine data, you can find patterns that will identify people. So, when you bring in, if you think about a wearable, GPS, your position data is in there. It's very hard to not identify people by position data. I mean, think about it in COVID, right? We know who you are. You're one of a limited number of people in the space you land every night. So we have to be really careful and thoughtful. Personal health information in these wearable devices is not considered medical data now. But I think as we start to merge these data, Human Health and Human Services in the US has talked about a mosaic that you put them together and you can actually create the image. So I do think that that's part of the question. I know it's one at the National Science Foundation. We spend a lot of time thinking about the ethics of this and how do we make sure that we're not uncovering things we shouldn't, but we are doing the things we should. So I think that's a key question as we go forward, but it is the fact that we can't get the data in some way is very good, but in another way, it adds all sorts of challenges.
Yeah, that's a real difficulty. I'm going to ask a throwaway question just because it's one that occurred to me while you were talking. Then we'll come back to this. But so if you were thinking about a fitness device, is that a biased sample? You're really getting people who are worried about fitness. How do you correct for that? Or are there alternate databases that you can track who goes to the Cupcake website or something? But
so the research, the research on fitness devices has been very clear. It's a select sample.
Yeah.
Also, most people don't use fitness devices. What happens is you put it on the first month, it's wow, look at this. And then at the end of the month, it sort of hits that drawer full of things. Those nice things that don't really, but now we have smart watches and these things become more, but remember, they're also biased and they're expensive. So, these are not, people that can afford to buy a smartwatch for a non-medical reason. That's a very different world. That's a lot of money to be spent on a throwaway disposable at some level or electronic disposable device, right? So I think we always have to take into account, as the devices, as the phones, my 83-year-old mom has the chip in her watch so she can make phone calls from her watch. I think as we start to do things that are more like that, where the watch and the phone become more like one, we may see more representative samples, but I think we do have to take care that we don't assume this is the general population.
No, I couldn't agree with you more, Wendy, and sadly, that's essentially my job is to try and be able to do that. So that's a bit challenging sometimes, but for me, I want to say a couple of things with regards to wearables. You're completely correct. And I am one of the worst offenders in this, in that I wear two wearables. So I have two wearables. And one is a smartwatch, which I have since moved away from using it from a health perspective to purely using it as a smartwatch. And another one, which is a much more sophisticated sensor that I use for different personal health information sets. And so for me, the key point of moving it away from being a nice, fun, shiny toy that you can get bored of and put in the drawer after a couple of months is to move it away from being purely understood as a fitness tracker. So it shouldn't necessarily, I think what we need is a mindset shift away from it being for fun and for sport, but really purely as a health. And if we go down the line of kind of socioeconomic determinants of health, and we look very much into how do we improve the socioeconomics of health, and from my perspective, and something that I'm very passionate about, is how do we shift healthcare from being curative to being preventative? And how do we work at keeping people healthy so that this becomes very much a tool to support health? And as you know, we've all seen through the pandemic, the phrase being used repeatedly is health is wealth. And so how do we not necessarily consumerize or monetize the use of these? And I'm thinking particularly around the reimbursement models with insurance companies, but how do we support a population to have greater access to their own health data that they're able to monitor and to work for a preventative to keep them healthy, rather than getting into the stage where we have to treat them when they're no longer healthy.
We've already gotten a question or two from the audience, but I'll slot them in later. Maybe I'll use that as a lead into something I was thinking about, is just off the top of your head and at a very high level, where do you think the greatest benefit for the use of AI is for healthcare and for diagnostics? Is it in research? Is it in clinical activities? Where when you think about, sort of from the 100,000 foot level, where are the big benefits we can see from AI in healthcare?
Oh, Wendy, do you want to go ahead?
I love this question. So do you want to do it, or you want me to start?
Oh, I think we can both do it. You start and I'll chip in afterwards.
Okay, I think it's both. I think it's completely transformative. So health has always been, we talk about a snapshot, right? You see your physician, you get tests then, you get images then. Everything is a snapshot in time. Then you walk out, What happens when you walk out? If you were, I'm somebody that has asthma. If I'm breathing well at the doctor, doesn't mean I'm not breathing well an hour from now. But my doctor says, but I saw you an hour ago. You look fine. But I'm not fine. So, and I'm lucky that I can advocate for myself in a way that makes sense. But we need data. We need usable, workable data. So we need actionable data. And I think this is where AI, this data transforms everything. It'll transform the research because clinical trials will be cut down to much shorter because we can collect a huge amount of data to make inferences about what's going to happen. So if I give you this medication, instead of waiting to see if you die or not, I can see the split. When I look at the data, I can see whose health is improving, whose is decreasing way earlier than I could have before. So it transforms the research. And actually, I think it transforms the behavioral field. So public health and behavioral medicine, this has always been a challenge. We don't have enough data on behavior. If we can get data on behavior, we can shape and transform that behavior in a way that helps people. You can't go to the clinic once every 6 months with diabetes and with poorly controlled hemoglobin A1C and say, oh, I'm going to see you every 6 months, but guess what? Your numbers are bad. We need more. We need so much more. And this is where I think this transforms everything from a moment in time. Don't get me wrong, physicians are working like crazy. Nurses are working so hard to make this work, but you can't do it on a slice in time piece of data. So when we give everybody these data and we can analyze it in a way it's actionable, then we transform the entire system because we can look at people as a whole, not as in a slice in time. So I think this is completely transformative to both the research and clinical care and public health. That's just my modest opinion on that.
It's probably the quote. It's the quote of the day so far. Completely transformative. So Caoimhe, top that.
I won't top it, but I'll add on to it because I couldn't agree with Wendy more. And one of the things that I really love, and it brings it back to the point, and that's why I'm quite so passionate about the use of wearables as a health tool, is about building that longitudinal data collection. And to Wendy's point, it's about essentially our physicians and our healthcare providers and our nurses are doing an incredible job, but they're doing an incredible job on an incomplete data set. And how on earth are we ever going to be able to support the right treatment for patients if they're working off incomplete data? So being able to have that whole holistic picture of data collected from 24/7. I mean, that's maybe a slight exaggeration on that one, but you know what I mean. If we're able to collect much more consistent data across the time points that may have problems, we look at things like, so I'm not a big fan of MS, that's the wrong way of putting it, but it's a disease area of development that I've worked in for quite a long time. And one of the things that I've spoken to an incredible KOL or key opinion leader in the US who says to me, I can't treat all the patients that I want to treat because it's so intensively heavy on that. And I'm always worried that I'm not going to identify a patient fast enough that is about to have a relapse. And how do I be able to identify and highlight patients that need interventional care before they have a relapse? So from my perspective it's being able, AI at the clinic level is completely transformational. It's about how do we ensure that and back to the preventative side of things, how do we catch something before it becomes a problem? How do we make sure the right patients are getting seen by their healthcare providers when they're needed to be seen? And it's a great equalizer as well for that geographic access to healthcare providers and specialists. By the ability to share data, use data in a wider perspective, you have the ability to get the people to the real specialists. So from a clinical perspective, there's a huge impact that AI can have on the lives of patients and those that are using it. But not only just that, if you look at you're not feeling well, you're not sure what's going on, and you go into your healthcare provider, you're undiagnosed with something. And I worked in clinical research, so my background is actually in clinical research. So I've done an awful lot of clinical trial design and how do you diagnose patients. And it's not nice, it's not fair, and it's quite unpleasant if you're going through that. There are a lot of physical samples collected. It could be potentially invasive. It's not particularly pleasant to go through. If you have the ability to have a digital footprint that a physician is able to look at and say, okay, well, these are the digital biomarkers that you're actually exhibiting, which would put you closer to the line of being at risk for this condition. So let's focus on the analysis of that instead of going through a broad spectrum of what on earth do you have? This is being able to develop non-invasive techniques to diagnose people and also be able to use data, large data sets to be able to predict the prognosis of particular people is transformative. And then if we go into the pure research end of it, Wendy talked a little bit about how we can speed up clinical trials, and that's massively important. If you have the ability and a validated digital biomarker that you can then use as a surrogate endpoint to your clinical trials, so we're not just waiting for someone to die or to relapse, but also that we're able to predict the success of that much earlier. It speeds up getting much needed drugs to market, both from the fact that we can get them there to patients faster, but also it increases the chances of drugs, which are, let's be very frank, a drug development process and pathway is an incredibly expensive thing to go down. And to be able to, you look at if you can make a drug development process faster and cheaper, then the drugs on the market are there to the patient faster and they're going to cost less, because the reason why drugs that we have cost so much is to recoup the research costs of being able to develop that. So those are totally transformative of points of how we can treat our patients better.
Yeah, the number I saw, whether it's accurate or not, is average is 2.6 billion to develop a new drug. And so billion is a lot, even in Washington. This fits into a question.
Can I add a comment to that too? Sorry.
Sure. Go ahead.
So I was just going to add on top of the 2.6 billion, it's also 12 to 15 years timeline to get a drug out.
Yeah.
Right. And I was going to say, a lot of AI is allowing us to combine data that we've never been able to combine before, and also to create models to be able to think about reuse of drugs, being able to safely model that, right? There's millions of drugs, or not millions, but there's many, many drugs that have been developed that were not effective. But can we look at those chemicals, compounds? I mean, it has this ability to completely transform this by being able to look at things and create models, not clinical trials, but be able to model these things. And especially with rare diseases, this is becoming the way we develop these, because you can only have so many people. But it reduces our cost, it increases the feasibility. It doesn't mean you don't need to test after, but you can create these amazing models for this.
And to Wendy's point as well, with regards to, we have developed a huge number of drugs. We have massive drug libraries of compounds that are safe, but they didn't actually deliver efficacy on the indication that they were developed for. But that doesn't mean that they can't have the ability to be impactful on something else. And that is where being able to build those models and really see the true potential of molecules that are developed. I mean, don't get me wrong, it won't in any way say that every non-efficacious drug that we have in a library will definitely have an efficacious target. No, but we will be able to look and take the work that has been done, so no work is lost, to be able to consistently try and screen for a much larger indication base that it could be used for.
Yeah, we know that there's a lot of examples of serendipity where people were developing one thing and it turned out to be effective in somewhere they weren't expecting. So if this can automate serendipity, that would be great. But this kind of fits into a question we got from the audience. It's from people at CSIS, which is at Georgetown and probably the leading think tank on artificial intelligence in some ways. And they asked, how can AI enable incorporation of research, say in genomics, into clinical decisions for precision medicine? That's their term. But that's kind of an interesting question. I don't know if any of you want to tackle it.
It's happening now. It's happening all over now. In some of the big research medical centers, you'll see this now. There's a lot of work in precision medicine. California, actually, state of California has a precision medicine initiative that they're using all of their academic medical center data to be able to do this. Bring the data together, create clinical decision support tools that can be used by providers. I think this is a huge area right now in the research community. We have researchers across the country, and I know they're around the globe, working not just in genomics. Actually, what's really interesting is when you bring, all the omics together, where you bring imaging, you bring, metabolomics, you bring genomics all together. If you bring all that data together, you get a much more complex image of a person. And you can understand that. Plus, we can use AI to scrape the research databases. So you can look for relationships. If you have something come out of your data that you say, I don't understand what this is, it doesn't make sense. You can use some of the AI tools now to search through all these other databases to figure out, has this been seen before? Was it published in a clinical report? Was it something? Because this is one of the ways we can find really interesting relationships that before were just never linked. So, but people are using this. I mean, especially when you look at heart disease, diabetes, cancer, this is, the cancer moonshot that the NIH is working on. This is a big part of how do you bring that data all together to create really good clinical decision support.
Yeah, and so a lot of it, to Wendy's point, a lot of it is being done in the research community at the moment, and it's about how do we scale that up into standard clinical practice, which is being done to a certain extent in oncology. There is quite a lot of precision treatments, precision oncology treatments that are going on there. But and that is because, you know, oncology is in the most simple terms, it's an incredibly rich environment for looking at from a genetic perspective on that, and there's a huge amount. One of the things that we need to look at, and specifically to the moonshot discussion, is that we are able to drive a more precision medicine approach to oncology because of the huge wealth of data around, tumor data that is available, clinical sample data that is available, and why we're so far ahead on oncology is because of the work that is being done there. But we need to also look at how do we move that across into other therapeutic areas as well, so that level of precision treatment is available to other therapeutic areas, and that's going to take something similar to moonshot, but for other conditions.
Yeah, well, Wendy was talking, I came up with a cheap one-liner, which is sort of PubMed on steroids, but that doesn't really capture the full range of what you're talking about. Let me ask about modeling and prediction, because modeling, I think it could make people nervous. You have this idea of digital twins sometimes. How does the technology change our ability to model? And you want to model, I would say, so you can predict. So how does this change modeling and prediction? What are you doing on that? What's the work on that we should be looking at?
So I will say at NSF, this is a big question that we have across a range of areas. One of the nice things about the National Science Foundation is, since we serve all the sciences and we're really developing like the AI tools, we can develop them across areas and then figure out, do they work, where do they work too? So then people can deploy them in different ways. But in AI, we've been able to, modeling traditionally was based on what the model was. You put the data in, you created a model. Many times they were physics-based. In AI, we can now start to create these models that maybe aren't intuitive and maybe can explain things, how things are working in a way they couldn't before. So I think what's important is, as much work as we have in biology and medicine, we still don't know how many things work. So the complex relationships. And so when you create these models, you can really start to look at how do these mechanisms work together and test some of these mechanisms outside the model. But it really helps us really understand how things work better. I mean, people think of it only for prediction. It's part of it is understanding. Models bring us understanding of processes in a different way. Prediction is really important because if I'm going to have a heart attack, if the way I'm going, if my data shows I'm going to have a heart attack within the next 6-month period, right? I want to know that, right? And maybe my doctor's told me multiple times, get your blood pressure, do this, do that. But maybe knowing I'm now at my risk is increasing by the day at this point. Maybe that's enough to help transform some of my behavior and make me follow recommendations better and all that. But it also may prescribe different medications. It may prescribe different ways of approaching this. And it may help a doctor who's never seen that appear in that way, see things differently too. So it allows you to bring a broader knowledge in every physician, every clinical practice has more knowledge. So they bring in the kind of the larger community's knowledge with these models. It doesn't mean you have to do it. There may be things happening when you're in a clinic that you say, this doesn't make sense. I'll give an example. We had a wonderful project that was looking at what was happening in the surgical suite with anesthesiologists. And what they did was they first created the model based on old data because they were trying to figure out what you could do differently to change the endpoints after surgery. So they did this great project that they looked at original data, they made the predictions, they created the predictive models, but then they ran it next to doctors and they observed what the AI taught them to do versus what the doctors did. And after surgery, took the doctors in and said, here's where we would have done this. And you did that. What were you thinking? What was happening? Then they merged them. Now that's in a large clinical trial. Because it now has the knowledge of watching and talking as well as the AI. So it becomes a much, much stronger system. So it has this then broad knowledge the models bring in.
We don't have time to talk about the sociology of research in AI, but maybe at the end. Caoimhe, did you want to add to that?
Yeah, I mean, one of the things that I wanted to pull out, Jim, is you used a very interesting word in your initial question, and that was the people are nervous of the models. And I think one of the things that we really need to lean into is explainable AI, because, you know, we need to be able to, nobody wants to use something that is perceived or seen as a black box. So what is the outcomes of these models? Really, those who are using them in a broader scale need to really understand how they work. And I think that is where we start to be able to mitigate some of that nervousness. And Wendy's example of the surgical experiment is incredible, because that is exactly how you bring people on board. You bring healthcare providers and users on board, and you actually build better models as well that are more trustworthy and that people believe in and understand better.
Yeah, let me build off some of that a little bit, because I was on my list of questions, which we're about halfway through. One of them is, how does this intersect with the development of augmented reality and virtual reality techniques? And so I was talking to on Wednesday somebody who is doing this for cars, you know, and so you could think of a group of engineers in a room with the car in front of them, right? And they could go inside. They could say, if I change this, what happens? Where's this? What's the genesis of this part? So engineering, ARVR is going to be engineering and manufacturing a lot of applications. How does that fit into what you're doing with AI in health?
So I'll just start it from the research perspective, so what you're talking is human AI teaming when you're talking about VR, AR like that. So I think we're going to see a lot of human AI teaming happening now. Right now, you'll see AR, VR, it's being used for surgical procedures on long distance, right? You know, can you help through something like that? You know, when you have somebody who, I mean, the Department of Defense has done a lot of work on this, right? So you're deployed, you don't have a cardiac expert, but somebody's got a hole in their heart. Somebody's got to do something, right? You have to save that service person. So you end up using an AR system to augment what people are doing to help. Now, you can imagine that happening throughout our country when you don't have the expertise in an area that you could use that. We're also seeing a lot of that happening in patient care for substance abuse, right? For anxiety treatments, where people can get, you know, in substance abuse, dealing with environments that make your anxiety go up, that increase your stress, that potentially are increasing your urge to use again. So understanding those processes, there's a lot in the VR, AR world that's coming in. And for anxiety, it's allowing people to expose themselves to the things that makes them anxious in a safe and comfortable environment. If you're, you know, so afraid of spiders that you can't go into a room by yourself, which just happens, right? Because there might be a spider in there. Having it in an AR and a VR, usually it's VR environment, you know, can allow that really intense anxiety to peak, drop, and you can get closer and closer. You can pet a spider in a virtual world. Think, you know, all these things that are very challenging to be able to do clinically now, we can do them with AR, VR. So,
great. Caoimhe.
I mean, just to add to what Wendy said, is that yes, there is a huge potential of that for the use of users, so patients or someone with a phobia such as Wendy has described as well. But it's also an incredible teaching tool for being able to teach healthcare providers by giving them access to particular presentations of patients that they may not have seen particularly there in their own practice, but they have the ability to do, to see that, especially from a surgical perspective as well. That's an incredibly valuable tool that will really round out kind of the support and the experience of healthcare providers.
Yeah, I was thinking while you were talking that you've got sort of, there's some things you can do with an artificial intelligence application where it can do the modeling. You can automate a lot of these processes. And then there's other, maybe what I would call more tactical applications that you could use AI and VR. So you're going to have this digital substitute that accelerates our ability to learn and to discover. Anyhow, all right. So, and I had a note here, put in plug for 5G. So a lot of this will depend on building out the infrastructure, which we're doing okay on, at least in the US, and certainly in some other countries. But when you think of that, and this sort of leads into a question, not 5G, if you want to talk about 5G, feel free. Where do we need to invest to accelerate what you guys are doing in your work? What are the investments, both public and private, that we need? And the easy answer is always, this always comes up when you do R&D. The answer is more. Okay, we'll take that one as a given. Where would you invest?
So I would always say more research because I work for a federal research agency. So I guess that's a no-brainer for me. But I think the work like what we do in Smart Health is really an exemplar of the work we do need to be doing to bringing together cutting edge science across the biomedical and technical realms, because that's what's going to come. That work is going to translate to so many different applications. I'm thinking when you're talking about ARVR, we have an initiative called the Future of Work, and they're doing all sorts of ARVR. Not all of it's in medicine, but a lot of what we're learning in that work will allow us to translate that to medicine, will allow us to translate that into practice. I'm sure it'll be useful in many different ways. So I think, but building up these teams in a way that makes sense, that, I'm a big fan of team science because I think it's really hard to do everything well. My researchers, you could spend your whole life reading just the computing literature. And then you have to know the biomedical. No, that doesn't work. So having the right team to, our support of the science around these teams, I think is critical because it advances health, it advances healthcare, but it also advances AI, which again feeds back into that whole system. So I know that's a broad answer, but I think research creates virtuous cycles of innovation that can help across industries and make a difference in the health of our country.
Great.
So to add on, and I fully agree that we need the investment in research as well, but I also think, and if I think further down the value chain on this, what we also need to invest in is upskilling and understanding of the technologies, because by developing fantastic models and what we can use is fantastic. And if I think specifically from my point of view with regards to digital technologies that can support patients, we can develop some wonderful solutions, whether it be a diagnostic algorithm or whether it be a wearable with a digital endpoint. These are great tools, but they're only as good as the adoption rates of using them. And I think we need to invest in upskilling the industry for really understanding why it is important to invest in this. Actually, to Wendy's point, is that if we can't get the people who really control the budgets and own the money to understand why we're investing in something like this, then we're always going to be slightly stuck on where the investment goes and how much is dedicated towards this area. But also we need to be educating the end users as to why it is important to use it. And wherever that end user be, whether it is a healthcare provider, a patient, a researcher themselves, being upskilled on a particular technology, I think investing in upskilling is key as well to the success and the sustainability of the funding for research.
Yeah, I'll draw off that to ask, what are the skills that researchers and clinicians will need as they move into this world? But I want to add a twist to that, which is, and how much of that can we automate, right? So how much of that do people need skills? How does the skill set they need change if you think about automating a lot of the tasks? I can give you a concrete example if that wasn't clear enough, but why don't we, Wendy, you look like you've sort of figured out what I was trying to say.
No, I was actually going to let my colleague go first on this one. I think she spent more time thinking about this than I have.
Well, I was at the dawn of quantitative research in another field, and what we did, of course, is develop tools. And so the tool that I happen to know the best was something called SPSS. This is the Stone Age, but suddenly you had a computer, you had a program, you had a data set, albeit messy. And the skills you needed to do research, you still needed some of the skills, the qualitative skills you once had, but you also needed these, what I'll call quantitative skills. And in some ways it eased the burden. It shifted how people did research, but automation can make this easier. So how does automation affect the skill set we'll need to? As you talked about upskilling, how does that fit in with automation and AI? Caoimhe, that was for you. You can look puzzled for another minute. Yeah.
So I'll profess that I'm not exactly an expert in upskilling. I'm aware that people need to be doing it. We have an incredibly talented upskilling program within the company that there's a specialist that manages that. So I'd probably refrain from making an uneducated statement on it. I just know that, to be very frank, when I look at if I'm looking at technologies that we're trying to implement in our patient population or with our healthcare providers, what I see is a lot of mistrust around the value that they bring. So when I talk about upskilling, I talk about very much the data provision that really shows how something that is being developed is actually delivering tangible benefits to the end users. So from my perspective, it is how do people understand and read data better rather than thinking of the traditional, which is yes, can you give me a dashboard? Can you get a data scientist to develop a dashboard for me? And I go, it's not quite what we'd use a data scientist for, but okay, it's about shifting that mindset and understanding that the skills that different roles bring into an organization and how we can really leverage the true value and that people specific subject matter expert roles can bring to that. And from my perspective, when I'm speaking to healthcare providers, is how do I convince them that digital biomarkers or longitudinal data measurements that give a complete picture of a patient are actually valid? And at the heart of it all, a lot of my end users are scientists. So it's all about provision of data. It's how do we make that data accessible and understandable, and have a large enough statistically powered data set that it is believable. So that would be my 2 cents on upskilling, because I have a very talented upskilling team that work within the company. So I wouldn't steal their thunder on that one.
So I think those were great points, but I also think there's the complexity here, because if we can really do what we're talking about, this transformation, it transforms the way the healthcare system works. If you can move to a more preventative framework by having better data, better tools, better everything. And it's not just a dashboard. That's clearly not. It's understanding how the team works and that, but you have less than you can think about. You have less time spent in diabetic ulcers, right? You have less time spent in all those things that go wrong. So we have to rethink how healthcare works, because that's in some level that those costs support a system, right? So we have to think about not just reskilling, but reframing these questions, because I've talked to providers many times, and it's like, we don't want the data. The data, what happens if we have the data and we don't act? Are we liable? I think we've gotten past that level of understanding what data needs to be provided and how. But also, what are you missing if we don't have that data? It has to be a very different question. Not just the liability of having data, but the liability of not having data. What we could be and should be. So I think, everybody's working really hard and always understand. I think our healthcare community is amazing, but they're working so much harder than we could make it easier to help them do what they're working so hard to do. But we have to rethink how we build out that world.
Yeah, there was a book in the 90s on the introduction of information technology. And I love the title. I think it was a book. It was called Paving Cow Paths. And that is that you get the new technology and then apply it to the old way of doing things, and you don't get the full benefit. So that is a big challenge. Let me close, because we're coming to the end. Let me close with a question that probably is a little unfair, and you've touched on it a lot, both of you. But it is the final question. So what's the future look like with this? What's the future with AI in healthcare? What are the things you would tell people to look for? Sort of immediate improvements and maybe long-term change?
I would say, I think you were looking at a lot more predictive models in terms of really helping patients and doctors manage their health more efficiently and effectively, because we understand, we can model what's changing over time. So if you have diabetes, and we have the right data in place, the right tools to have people understand that data, we can have people start to see changes over time, and then not in a 6-month time frame, in a shorter time frame, in a way that makes sense. And I think it will be really helpful. So I think you're going to see more and more of that. I think you're going to see more. I think you're going to see in the clinical trial research world lots of transformation that COVID started. I did a workshop on digital clinical trials in 2019, probably a matter of months before COVID hit, and everybody was kind of like, this is such a great idea, but no. And I mean, we had the FDA there. Everybody was really excited. It was an NIH and NSF. But I think but yes, we have to figure out how to do this. So I think there's transformations coming in all of these areas now, and we're going to see it.
Great. Caoimhe, you got the final comment.
Oh, I'm very honored and flattered. So I better make it a good one. So from my perspective, apart from saying the future is awesome, because I genuinely believe it is, and I think there's a huge amount of scope and potential that can be used here, I would say that I see an awful lot more AI supported prescribing behaviors of physicians, of being able to not only be able to pick the best molecular therapeutic for a patient, but also the best dosage and the best regime for treatment. So I would say there a lot of that. And to add on top of that as well, which is always slightly controversial when you work for a pharma company, is what treatment is available outside of the drug. What is the AI supported behavioral change that patients can do that can really improve their health outside of additional molecular intervention? And so that I see a lot coming in moving forward.
Great. No, I'm an optimist too, and I think that's one of the things that I hope we can get out of this series is if we do this right, everyone will be better off. And I think there's a fair chance that we'll do it right. But Wendy, Nilsen, Caoimhe, Vallely-Gilroy, thank you very much for being on our panel. For the audience, these remarks are recorded and they'll be available on YouTube, Spotify, Apple, and the CSIS website. Everyone have a good rest of their day and a good weekend. Thank you.
Thanks, sir.